Question 1. Patient assessment. Diagnostic testing. A patient with chronic kidney disease (CKD) presents for evaluation. The patient's lab results show elevated BUN and creatinine levels, GFR of 18 mmHg on 0.73 and hyperkalemia. Which diagnostic test would be most appropriate to assess the structural integrity of the kidneys? A. Renal ultrasound. B. Urinalysis. C. 24-hour urine collection. D. Renal biopsy. Answer A. Renal ultrasound. Explanation. Renal ultrasound. This is the most appropriate diagnostic test to assess kidney size, structure, and any anatomical abnormalities like cysts or obstructions. It is non-invasive and widely used for CKD evaluations. Urinalysis. While helpful in detecting proteinuria or hematuria, it does not provide structural information. 24-hour urine collection. Useful for evaluating specific kidney functions like protein excretion or creatinine clearance, but not structural abnormalities. Renal biopsy. Typically reserved for cases where the cause of kidney dysfunction is unclear or when there is suspicion of specific diseases like glomerulonephritis. This approach aligns with KDIGO guidelines emphasizing non-invasive methods for initial assessments. Question 2. Treatment modalities. Hemodialysis. During a routine hemodialysis session, a patient develops sudden hypotension and nausea. Which of the following interventions should the nurse prioritize? A. Administer a bolus of normal saline and lower the ultrafiltration rate. B. Stop the dialysis and remove the needles immediately. C. Increase the dialysate temperature to stabilize blood pressure. D. Provide the patient with a glass of water to improve hydration. Answer A. Administer a bolus of normal saline and lower the ultrafiltration rate. Explanation. Administering normal saline. This helps restore intravascular volume, addressing the acute hypotension. Lowering the ultrafiltration rate reduces fluid removal, preventing further volume depletion. Stopping dialysis immediately. This is not necessary unless the hypotension is severe and unresponsive to initial measures. Increasing dialysate temperature. Contraindicated. Cooler dialysate is often used to stabilize blood pressure. Providing water orally. Oral intake is ineffective in acute situations due to the time required for absorption. The recommended approach adheres to KDOQI guidelines for managing intradialytic hypotension. Question 3. Scenario-based question. Pharmacology and nephrology. Case scenario. Mrs. Taylor, a 65-year-old woman with stage 4 CKD, has been prescribed a new medication for managing hyperphosphatemia. She reports feeling nauseous after meals and has difficulty adhering to the dosing schedule. Upon review, you note that she has been prescribed calcium carbonate to be taken with meals. What would be the most appropriate intervention to address her concerns? A. Educate her on splitting the dose across meals to reduce gastrointestinal side effects. B. Discontinue the calcium carbonate and switch to an iron-based phosphate binder. C. Advise her to take the medication on an empty stomach to avoid nausea. D. Increase the dose to compensate for missed doses. Answer A. Educate her on splitting the dose across meals to reduce gastrointestinal side effects. Explanation. Splitting doses. Taking smaller amounts of calcium carbonate with meals can minimize nausea while ensuring effectiveness in binding dietary phosphorus. Switching medications. This may be an option if side effects persist, but adherence education should be prioritized first. Taken on an empty stomach. Calcium carbonate is the phosphate binder and works by binding phosphorus in the gut, requiring it to be taken with food. Increasing the dose. This can exacerbate side effects and lead to calcium overload, increasing the risk of vascular calcification. This strategy aligns with clinical guidelines emphasizing patient education and adherence in managing CAD complications. Question 4. Complications and emergency management. Dialysis-related complications. A patient undergoing hemodialysis reports itching, muscle cramps, and difficulty breathing. Upon examination, the nurse notices signs of chest pain and hypotension. What is the most likely complication and how should it be managed? A. Air embolism. Stop dialysis. Place the patient in the Trendelenburg position and administer oxygen. B. Dialyzer reaction. Discontinue the current dialyzer and switch to an alternative. C. Hypokalemia. Administer potassium chloride intravenously. D. Fluid overload. Increase the ultrafiltration rate and provide loop diuretics. Answer A. Air embolism. Stop dialysis. Place the patient in the Trendelenburg position and administer oxygen. Explanation. Air embolism. The symptoms described, including chest pain, hypotension, and respiratory difficulty, suggest an air embolism. Immediate intervention involves stopping dialysis, placing the patient in the Trendelenburg position to trap the air embolus, and administering oxygen. Dialyzer reaction, typically present. Itching and mild symptoms without hypotension or chest pain. Hypokalemia, rare in this context. Hemodialysis more commonly corrects hypokalemia. Fluid overload, unlikely given the acute onset of symptoms during dialysis. This follows CMS and KDOQI guidelines for managing dialysis emergencies. Question 5. Nutrition in nephrology. Dietary recommendation for CE. A patient with CKD stage 3 asks about dietary changes to manage the condition. Which of the following should the nurse prioritize when educating the patient? A. Limit potassium, phosphorus, and protein intake while ensuring adequate caloric intake. B. Restrict sodium and fluids, but increase protein intake to support kidney function. C. Avoid carbohydrates and focus on a high-protein, low-fat diet. D. Eliminate dairy and fruits entirely to avoid complications. Answer A. Limit potassium, phosphorus, and protein intake while ensuring adequate caloric intake. Explanation. Limiting potassium, phosphorus, and protein. This is essential in CAD to prevent hyperkalemia, hyperphosphatemia, and further kidney damage. Adequate caloric intake prevents malnutrition, restricting sodium and fluids. Important but not at the expense of balanced nutrition. Increased protein intake can worsen CKD progression. Avoiding carbohydrates. Not typically necessary unless the patient has diabetes. Eliminating dairy and fruits, unnecessary. The focus should be on choosing low potassium and low phosphorus options. These recommendations align with NKF and KD nutritional guidelines. Question 6. Scenario-based question. Special populations. Case scenario. Mr. Evans, a 72-year-old male with CKD stage 4, is experiencing cognitive decline and difficulty adhering to his medication schedule. His caregiver reports missed doses of phosphate binders and antihypertensives. What is the most appropriate nursing intervention? A. Refer Mr. Evans to a geriatric specialist for further cognitive assessment and management. B. Educate the caregiver about setting up a pill organizer and monitoring adherence. C. Discontinue phosphate binders and focus on controlling blood pressure. D. Adjust his medications to once daily dosing and eliminate non-essential drugs. Answer. B. Educate the caregiver about setting up a pill organizer and monitoring adherence. Explanation. Caregiver education involving the caregiver ensures medication adherence in patients with cognitive decline. A pill organizer simplifies complex schedules. Geriatric specialist referral. While valuable, this does not address immediate adherence concerns. Discontinuing phosphate binders. This would lead to complications like hyperphosphatemia, vascular calcification, adjusting medications. Simplification is useful, but discontinuing essential drugs can worsen CKD progression. This approach aligns with evidence-based care models for managing CKD in geriatric patients. Question 7. Professional practice. Ethical and legal considerations. A patient with ESEB refuses dialysis and opts for palliative care. The family disagrees with the decision and demands that the treatment continues. What is the nurse's ethical obligation in this situation? A. Respect the patient's decision and provide education to the family about the patient's rights. B. Follow the family's wishes and continue dialysis until they agree otherwise. C. Seek court order to override the patient's decision and ensure life-sustaining treatment. D. Discharge the patient for refusing treatment and document the non-compliance. Answer A. Respect the patient's decision and provide education to the family about the patient's rights. Explanation. Respecting autonomy. Ethical principles and the Honor Code of Ethics prioritize patient autonomy, especially in end-of-life decisions. Following family wishes. This disregards the patient's rights and violates ethical guidelines. Seeking court order. Rarely appropriate unless there is evidence of coercion or incapacity. Discharging the patient. Unethical and contrary to standards of palliative care. This follows CMS and honor ethical guidelines on patient-centered care and autonomy. Question 8. Pharmacology in nephrology. Renally adjusted medications. Which medication requires dose adjustment in a patient with a D of 25 mmHg on 0.73 to avoid toxicity? A. Vancomycin. B. Lisinopril. C. Warfarin. D. Atorvastatin. Answer A. Vancomycin. Explanation. Vancomycin, eliminated renally. Improper adjustment in CKD can lead to nephrotoxicity and not toxicity. Lisinopril requires caution but not necessarily dose adjustment at this GFR unless hyperkalemia occurs. Warfarin metabolized by the liver, so renal impairment has minimal impact on dosing. Atorvastatin does not require renal dose adjustments. This approach is consistent with renal pharmacology best practices and FDA guidelines. Question 9. Infection control in nephrology. Preventing healthcare-associated infections. A dialysis center reports a rise in bloodstream infections. Which of the following interventions should the nurse prioritize to reduce infection rates? A. Implementing a rigorous hand hygiene program and training staff on aseptic techniques. B. Switching all patients to AF fistulas regardless of vascular access history. C. Increasing the frequency of dialyzer reuse to prevent contamination. D. Restricting the use of antibiotics to avoid resistance. Answer A. Implementing a rigorous hand hygiene program and training staff on aseptic techniques. Explanation: hand hygiene and aseptic techniques proven to significantly reduce bloodstream infections in dialysis settings. CDC guidelines. Switching to AF fistulas, ideal but not immediately feasible for all patients. Increasing dialyzer reuse can increase contamination risk if not properly sterilized. Restricting antibiotics, but unrelated to infection prevention protocols. This aligns with CDC and WHO infection control recommendations. Question 10. Foundations of nephrology nursing. Fluid and electrolyte balance. A patient with acid presence with confusion, muscle weakness, and peak T waves on a neck. Which electrolyte imbalance is most likely and what is the initial treatment? A. Hyperkalemia. Administer calcium gluconate and insulin with glucose. B. Hyponatremia. Administer normal saline and diuretics. C. Hypocalcemia. Provide oral calcium supplements. D. Hypophosphatemia. Prescribe phosphate binders and initiate dialysis. Answer A. Hyperkalemia. Administer calcium gluconate and insulin with glucose. Explanation: hyperkalemia. The symptoms and changes indicate life-threatening potassium elevation. Calcium gluconate stabilizes cardiac membranes, while insulin and glucose shift potassium intracellularly. Hyponatremia, unlikely given the presentation. Hypocalcemia does not cause changes like peak T waves. Hypophosphatemia does not. Acute symptoms like confusion and cardiac changes. These management strategies are based on KDIGO guidelines for hyperkalemia in E. Question 11. Fluid management. Dialysis prescription adjustments. A patient on hemodialysis presents with persistent hypotension during treatments. What is the most appropriate intervention to manage this issue? A. Increase the dialysate temperature to enhance vasoconstriction. B. Administer midodrine 30 minutes before dialysis sessions. C. Reduce the ultrafiltration rate and switch to daily dialysis. D. Administer a hypertonic saline bolus during each dialysis session. Answer B. Administer midodrine 30 minutes before dialysis sessions. Explanation: midodrine, this alpha agonist, increases vascular tone and reduces the likelihood of hypotension during dialysis. Increasing dialysate temperature may worsen hypotension due to vasodilation. Reducing ultrafiltration rate and daily dialysis. Effective long-term strategies, but not immediately practical for all patients. Hypertonic saline bolus, temp fix not a sustainable solution. Management aligns with KDIGO recommendations for dialysis-related hypotension. Question 12. Patient education. Peritoneal dialysis training. During a training session for a patient starting peritoneal dialysis, the patient asks what signs indicate peritonitis. What should the nurse emphasize as the most critical signs? A. Fever, nausea, and increased appetite. B. Cloudy dialysate outflow, abdominal pain, and fever. C. Weight gain, hypertension, and decreased urine output. D. Itching, muscle cramps, and hypotension. Answer B. Cloudy dialysate outflow, abdominal pain, and fever. Explanation: cloudy dialysate outflow, the hallmark sign of peritonitis in peritoneal dialysis patients. Abdominal pain and fever often accompany it. Other options describe unrelated complications such as fluid overload. C. Or uremic symptoms. D. Educating patients on recognizing peritonitis is crucial to initiating timely treatment and preventing complications. Question 13. Vascular access. AF fistula complications. A patient with an AF fistula for hemodialysis reports numbness and tingling in the hand on the same side as the fistula. What is the most likely complication? A. Stenosis of the fistula. B. Steele syndrome. C. Infection at the access site. D. Thrombosis of the fistula. Answer: B. Steele syndrome. Explanation: Steele syndrome occurs when the fistula diverts excessive blood flow away from the distal extremity, leading to ischemic symptoms like numbness and tingling. Stenosis would present as reduced blood flow or difficulty in cannulation. Infection would present with localized redness, warmth, and drainage. Thrombosis typically leads to loss of thrill and brute, not numbness. Management involves vascular assessment and surgical correction. Question 14. Infection control. Catheter care. What is the most effective nursing intervention to prevent catheter-related bloodstream infections in patients with tunneled hemodialysis catheters? A. Routine antibiotic prophylaxis before dialysis sessions. B. Using chlorhexidine for catheter site care and dressing changes. C. Switching to AV fistulas for all patients. D. Performing daily catheter flushes with heparin. Answer: B. Using chlorhexidine for catheter site care and dressing changes. Explanation: Chlorhexidine proven to reduce infection rates when used for catheter site care according to CDC and KDIGO guidelines. Routine antibiotic prophylaxis not recommended due to the risk of resistance. Switching to AV fistulas ideal but not always immediately feasible for all patients. Daily catheter flushes with heparin prevents clotting but limited impact on infection prevention. Proper adherence to aseptic techniques and evidence-based protocols is critical in reducing bloodstream infections. Question 15. Scenario-based question. Acute kidney injury in a post-operative patient. Mr. Thompson, a 65-year-old male with no history of kidney disease, is admitted to the ICU following major abdominal surgery. His urine output has decreased to less than 20 ml/hour for the past 6 hours. His labs show elevated BUN and creatinine levels. Blood pressure is 96 mmHg and he exhibits signs of edema. Based on these findings, what is the nurse's immediate priority? A. Administer a fluid bolus to improve perfusion and urine output. B. Start continuous renal replacement therapy. C. Administer a diuretic to reduce fluid overload. D. Obtain a nephrology consultation to evaluate for dialysis. Answer: A. Administer fluid bolus to improve perfusion and urine output. Explanation: Fluid bolus addresses possible prerenal causes of acute kidney injury by improving renal perfusion. Hypotension and decreased urine output suggest hypovolemia as a potential QRT, and dialysis indicated for refractory acute or when fluid overload is life-threatening but not the initial step. Diuretics not appropriate. Hypovolemic states as they may worsen renal perfusion. KDIGO guidelines emphasize addressing reversible causes of acute, such as hypovolemia, before initiating renal replacement therapies. Question 16. Hemodialysis hypotension management. A patient undergoing hemodialysis experiences a significant drop in blood pressure, a P, 80-50 mmHg during the session. Which of the following should the nurse implement first to address the hypotension? A. Reduce the ultrafiltration rate. B. Administer intravenous albumin. C. Stop the dialysis session immediately. D. Trendelenburg position with oxygen administration. Answer: A. Reduce the ultrafiltration rate. Explanation: Reducing ultrafiltration rate helps alleviate the primary cause of dialysis-related hypotension, excessive fluid removal. Intravenous albumin may be appropriate in cases of severe hypotension or hypoalbuminemia, but is not the initial intervention. Stopping the dialysis session rarely necessary unless hypotension becomes unresponsive to other measures. Trendelenburg position can be used as supportive measure but does not address the underlying fluid imbalance. Per KDIGO and KDOKI guidelines, adjusting ultrafiltration is the first-line intervention. Dialysis-related hypotension. Question 17. Pharmacology. Erythropoiesis-stimulating agents. The patient with chronic kidney disease (CKD) is prescribed an erythropoiesis-stimulating agent (ESA). Which laboratory value should the nurse monitor closely to ensure safe and effective treatment? A. Potassium levels. B. Hemoglobin levels. C. Serum calcium levels. D. GFR glomerular filtration rate. Answer: B. Hemoglobin levels. Explanation: Hemoglobin levels. ESA therapy aims to correct anemia but must be monitored to avoid overcorrection 11 grams to low, which increases the risk of thromboembolic events. Potassium and calcium levels important in CKD management but unrelated to ESA therapy specifically. Jafar, indicates kidney function but does not directly influence ESA dosing. KDIGO guidelines recommend hemoglobin monitoring to balance anemia management and associated risks. Question 18, scenario-based question. Peritoneal dialysis complications. Mrs. Anderson, a 55-year-old peritoneal dialysis PD patient, calls the clinic complaining of abdominal pain, fever, and cloudy effluent. What should the nurse prioritize in this situation? A. Advise her to skip her next dialysis session and come to the clinic in 24 hours. B. Instruct her to send the dialysis effluent for culture and sensitivity testing immediately. C. Suggest increasing her protein intake to support healing. D. Change her PD catheter dressing to minimize infection risk. Answer. B. Instruct her to send the dialysis effluent for culture and sensitivity testing immediately. Explanation. Culture and sensitivity testing, the most critical step in diagnosing peritonitis, a common and serious PD complication. Skipping dialysis delays treatment and may worsen fluid and toxin accumulation. Protein intake and catheter dressing, important but secondary to diagnosing and treating the infection. Identification and treatment of peritonitis per ISP guidelines are essential for preventing severe complications. Question 19. Hyperkalemia management in AE. Patient presents with hyperkalemia, serum potassium 6.5 mcl. Which intervention is most appropriate to stabilize the cardiac membrane while other treatments are initiated? A. Administer sodium bicarbonate or administer calcium gluconate or start a potassium binding resin. D. Prepare the patient for emergency hemodialysis. Answer. B. Administer calcium gluconate. Explanation. Calcium gluconate stabilizes cardiac membranes and prevents arrhythmias without altering serum potassium levels. Sodium bicarbonate and potassium binding resins dress the potassium level but take longer to act. Emergency hemodialysis, reserved for severe or refractory hyperkalemia. The KDIGO guidelines prioritize cardiac stabilization before potassium reduction hyperkalemic emergencies. Question 20. Nutrition management in CKD. Which dietary recommendation is most appropriate for a patient with CKD, stage 4 and elevated phosphorus levels? A. Encourage high protein intake to maintain muscle mass. B. Avoid dairy products and high phosphorus foods. C. Liberalize fluid intake to enhance phosphorus excretion. D. Recommend potassium supplements to balance electrolyte levels. Answer. B. Avoid dairy products and high phosphorus foods. Explanation. Phosphorus restriction prevents complications like vascular calcification and secondary hyperparathyroidism. High protein diets increase phosphorus intake and are contraindicated in advanced CKD unless the patient is on dialysis. Fluid intake does not influence phosphorus excretion, which relies on dietary control and phosphate binders. Potassium supplements not recommended unless a deficiency exists, and they are generally avoided due to hyperkalemia risk in CKD. Adherence to dietary restrictions per KDIGO guidelines is essential in managing CKD complications effectively. Question 21. Medication management. Phosphate binders. A patient with CKD stage 5 has been prescribed sevelamer hydrochloride. What is the primary purpose of this medication? A. Lower serum potassium levels. B. Reduce intestinal absorption of phosphorus. C. Correct metabolic acidosis. D. Increase calcium absorption in the gut. Answer. B. Reduce intestinal absorption of phosphorus. Explanation. Sevelamer hydrochloride, a non-calcium-based phosphate binder that prevents phosphorus absorption in the gastrointestinal tract, helping to manage hyperphosphatemia in CKD. Potassium levels, not directly affected by sevelamer metabolic acidosis correction, achieved with bicarbonate supplementation. Calcium absorption may require active vitamin D supplementation. Phosphate binders. Effective phosphorus management minimizes the risk of secondary hyperparathyroidism and vascular calcifications. Question 22. Fluid management in dialysis patients. A hemodialysis patient reports persistent thirst and difficulty adhering to fluid restrictions. Which strategy should the nurse recommend to help manage fluid intake? A. Encourage the use of caffeinated beverages as a diuretic. B. Suggest consuming iced chips instead of liquid beverages. C. Increase salt intake to balance fluid retention. D. Allow unlimited water intake on non-dialysis days. Answer. B. Suggest consuming iced chips instead of liquid beverages. Explanation. Iced chips helps satisfy thirst while providing minimal fluid volume. Caffeinated beverages and increased salt intake can worsen fluid retention and increase thirst. Unlimited water intake contradicts fluid restriction principles essential for preventing fluid overload. Adhering to fluid restrictions is crucial for managing interdialytic weight gain, maintaining hemodynamic stability. Question 23. Vascular access complications. A patient with a new arteriovenous fistula reports swelling and redness around the site. What is the nurse's priority action? A. Encourage the patient to exercise the affected arm to promote blood flow. B. Apply warm compresses to the site to reduce swelling. C. Assess for signs of infection and notify the healthcare provider. D. Advise the patient to wait and monitor symptoms for 24 hours. Answer. C. Assess for signs of infection and notify the healthcare provider. Explanation. Signs of infection. Swelling, redness, and tenderness around the fistula may indicate infection or thrombosis, requiring prompt medical evaluation. Exercise and warm compresses may worsen the condition if infection is present. Delaying intervention can lead to complications like sepsis or fistula failure. Preventing and addressing vascular access complications is critical for ensuring effective dialysis treatment. Question 24. Complication management. Dialysis disequilibrium syndrome. A patient develops nausea, confusion, and a headache during their first hemodialysis session. What is the most likely cause? A. Hypoglycemia. B. Dialysis disequilibrium syndrome, DDS. C. Hyperkalemia. D. Infection. Answer. B. Dialysis disequilibrium syndrome, DDS. Explanation. DDS occurs due to rapid shifts in fluid and electrolytes during initial dialysis, causing cerebral edema, hypoglycemia, and hyperkalemia. Less likely with symptoms primarily involving neurologic changes. Infection rarely develops during the first session and usually involves fever and localized signs. Preventing DDS involves initiating dialysis at a slow rate for new patients and closely monitoring symptoms. Question 25. Nutrition education. Protein intake in EE. A patient with CKD stage 3 asks about protein intake. What is the most appropriate dietary recommendation? A. High protein diet to prevent muscle wasting. B. Plant-based protein sources to reduce metabolic burden. C. Eliminate protein entirely to protect kidney function. D. Unrestricted protein intake as kidney damage is irreversible. Answer. B. Plant-based protein sources to reduce metabolic burden. Explanation. Plant-based proteins provide essential nutrients while generating fewer nitrogenous wastes compared to animal proteins, easing the kidney's workload. High-protein diets increase the risk of uremic toxin accumulation. Eliminating protein leads to malnutrition and worsens health outcomes. Unrestricted protein intake contradicts dietary management guidelines for CKD. Adequate protein intake, as per KDIGO recommendations, balances nutritional needs with renal function preservation. Question 26. Anemia management in EAE. A patient with CKD has a hemoglobin level of 9.5 grams still and is prescribed an erythropoiesis-stimulating agent, ESA. What additional intervention is typically required for effective anemia management? A. High-dose vitamin C supplementation. B. Intravenous or oral iron therapy. C. Increased fluid intake to improve circulation. D. Administration of blood transfusions. Answer. B. Intravenous or oral iron therapy. Explanation. Iron therapy necessary to support red blood cell production stimulated by ESA therapy, as iron deficiency is common in CKD. Vitamin C does not directly address anemia in CKD. Increased fluid intake, not related to hemoglobin levels or iron stores. Blood transfusions, reserved for severe anemia or when ESA therapy is contraindicated. Iron supplementation and ESA used together optimize anemia management and improve quality of life in CKD patients. Question 27. Blood pressure goals in EE. A patient without diabetes has a blood pressure of 148/92 mmHg. According to KDIGO guidelines, what is the recommended blood pressure target for this patient? A. Less than 149 mmHg. B. Less than 138 mmHg. C. Less than 159 mmHg. D. Less than 128 mmHg. Answer A. Less than 149 mHg. Explanation: the KDIGO guidelines suggest a target of less than 149 mHg for patients without significant proteinuria to reduce the risk of CAD progression and cardiovascular complications. A lower target, 138 mHg, may apply to patients with proteinuria. 159 mHg is not aligned with C goals, and 128 mHg is overly stringent for most CAD patients. Individualized blood pressure management considers comorbidities, age, and overall cardiovascular risk. Question 28. Bone mineral disorders in EE. A patient with CKD has an elevated serum phosphorus level and low calcium. What is the primary cause of this imbalance? A. Increased calcium absorption in the gut. B. Impaired phosphate excretion by the kidneys. C. Overproduction of erythropoietin. D. Excessive dietary phosphate intake. Answer: B. Impaired phosphate excretion by the kidneys. Explanation: CKD reduces the kidney's ability to excrete phosphorus, leading to hyperphosphatemia. This condition stimulates secondary hyperparathyroidism, contributing to low calcium levels. Erythropoietin overproduction and dietary intake are not primary factors in CKD-related mineral imbalances. Proper management, including dietary phosphorus restriction and phosphate binders, is critical for preventing complications like vascular calcification and bone disease. Question 29. Uremic symptoms in EE. EE stage 4 patient complains of nausea, fatigue, and a metallic taste in their mouth. These symptoms are most likely due to A. Hyperkalemia, B. Uremia, C. Metabolic acidosis, D. Anemia. Answer: B. Uremia. Explanation: uremia, the accumulation of nitrogenous waste products in the blood due to declining kidney function, causes systemic symptoms including nausea, fatigue, and taste alterations. Hyperkalemia primarily affects cardiac and neuromuscular systems. Metabolic acidosis causes fatigue and bone resorption but not a metallic taste. Anemia contributes to fatigue but not nausea or altered taste. Mon for uremic symptoms helps guide decisions regarding initiation of dialysis. Question 30. Peritoneal dialysis complication. Peritonitis. A peritoneal dialysis patient reports cloudy, dialysate, abdominal pain, and fever with the most likely diagnosis: A. Catheter obstruction, B. Hypovolemia, C. Peritonitis, D. Electrolyte imbalance. Answer: C. Peritonitis. Explanation: cloudy, dialysate, abdominal pain, and fever are hallmark signs of peritonitis. A common and serious complication of peritoneal dialysis. Catheter obstruction, presents with poor dialysate flow rather than systemic symptoms. Hypovolemia manifests as edema or shortness of breath, not fever or pain. Electrolyte imbalances have varied symptoms depending on the specific imbalance but do not cause dialysate. Immediate treatment with antibiotics is essential to prevent severe complications and preserve peritoneal membrane function.